Welcome back to Evolving Paradigms in Castration-Resistant Prostate Cancer. We're now going to go through our third and final case. This is a case of a 71-year-old man with metastatic CRPC who presents with a rising PSA 18 months following treatment with abiraterone and prednisone. Imaging at that time reveals multifocal bone lesions without visceral metastasis. He has moderate bone pain requiring 1 to 2 doses of oxycodone per day, and then the question is, what next? So let's first point out that this is a patient who's been on abiraterone for 18 months, so presumably has had some benefit from it. Dr. Petrolak, what are your thoughts as you approach this case?
So that's one of the factors that I look at in this particular patient. How long has he responded to his previous hormone therapy? The choices that we have at this point are enzalutamide, docetaxel, or radium. And again, we've got to try to individualize that. So generally, we've not seen second responses, or it's not common to see other responses to enzalutamide. However, in my clinical experience, those patients who have a prolonged response to their previous hormone therapy, such as abiraterone, may be a little bit more likely to respond to these other agents. And perhaps that has something to do with the emergence of the ARV7 clone or some other resistance factors. So then I think the real choice is between docetaxel or radium. And chemotherapy does improve pain. It does improve survival. It will help to, this patient does not have any nodal disease nor visceral disease, so that's really not an issue. The issue of radium versus chemo is difficult. I probably would go with chemotherapy in this particular patient because the pain relief with radium is not as clear as I would like it to be. I know that I can get a good pain relief with chemotherapy, within 1 to 2 cycles. So I probably would go with docetaxel in this patient.
Dr. Sartor?
Really a bit of a conundrum. First of all, I like to divide the world into what we know and what we don't know. And these sort of abiprogressors, in truth, we don't really know what is the best thing because we just don't have the type of trials that would enable us to draw strong conclusions. So when I see this patient and look at the distribution metastasis and the bone lesions, I do have radium on my mind, and that may be because I've had a fair amount of experience with it. I definitely have docetaxel on my mind. And then I have something that we didn't talk about on my mind as well. There's an interesting publication from Dr. De Bono over in London. Instead of abiprednisone, he did abidexamethasone. And
yes.
Don't ask me why, because he can't explain why and I can't explain why, that a 0.5 milligram or 0.75 milligrams of dexamethasone might actually be able to switch this progressor into a responder. And it's variable here, and so it's a little bit tough, but I probably would have done it before now. If I'd been seeing that PSA consecutively rising before he started having this bone pain, I might have done that Pred-Dex switch, as I called it. I don't know if you ever do that.
Oh, I do 0.5 BID of dexamethasone quite frequently.
BID.
Yep.
Okay.
And some of the, I will say this categorically, some of the best clinical responses I have seen in CRPC have come from that regimen. Not adding it to abiraterone, just giving it by itself even.
Yeah. Well, that, to me, it's a separate issue. I have absolutely no qualms about using the dexamethasone, 0.75 milligrams in my experience.
Yeah.
But in this kind of Pred-Dex switch right here, some of the patients do amazingly better on dexamethasone. I don't understand it. I asked Johan, he doesn't understand it.
It's a low-cost thing to do. There's definitely a hormonal thing going on. Let's just say we now know, for example, we saw this morning that the glucocorticoid receptor may be upregulated in the setting of resistance. We've seen it in one of the presentations today suggested that it goes up in the context of abiraterone therapy. So we really need to dive into this area a little bit more. And maybe this is a good time for us to mention that our center and a number of centers on the West Coast are doing biopsies on exactly this type of patient with the goal of determining what are the pathways that are active in these patients. And again, Eric Small, my colleague, did a really great presentation today, I think, showing that this disease at this point is beginning to sort of diversify, if I could use that term, or evolve is maybe the better term, into taking on different histologies. And we've all known that for a long time that one can see small cell carcinoma type tumors develop in patients with prostate cancer, but I don't think we realize the extent to which it occurs, which is somewhere between, maybe around 20, 25, even higher percentages. But we also are finding out that the small cell / neuroendocrine cancers that evolve in prostate cancer patients don't follow the patterns we thought they would. They're not all liver metastasis. They're not all patients with low PSAs. In fact, we're seeing neuroendocrine and small cell phenotype develop in lymph nodes with high PSAs. And so that's really remarkable, and it's both enlightening and disturbing at the same time, to be honest with you. But it's suggesting that at some point we will get to a phase where we do biopsies routinely in this setting, and we make treatment decisions based on that. I firmly believe that. Yeah. I think we're moving there quite rapidly.
Well, it's interesting because I think we might even already be moving beyond that a little bit, because the circulating free DNA, some of the exosomal stuff we're now starting to see, and it's at the fringes, but nevertheless it's moving pretty rapidly. Sometimes it's hard to put a needle in the tumor, and it's easy to draw a liquid biopsy, and until this evolution in data sort of comes about, I'm not quite sure what to say. But by the way, I love that presentation that Eric gave today. It was really quite informative. It indicated that, yes, we have these typical adenocarcinomas, and then we have a much higher percentage of these cells that are not quite what we thought they were going to be. And it's not just in the liver. It could be bone, lymph nodes, anywhere else. So, oh boy.
And there's something in the middle, right?
Oh, yes, absolutely. There's something in the middle. It's a spectrum.
Right.
I mean, trying to get back to this sort of, clinical decision making here, I'm going to echo one of the things that Dan pointed out, that some of the patients who have these longer responses to the ABI are perhaps a little more responsive to something like enzalutamide. And that's a soft call, not a hard call. But there's some patients who go from ABI to enza who do pretty well, and then there are many who don't. But one of the things that was biased in those initial presentations, they were enriching the population for people who had very poor or very short responses to ABI. And so when they did that ABI-enza switch, it often was in a subset of patients who had pretty rapid progression on the ABI. This is not that patient. We don't actually have much data. I'd like to point out what we don't know. And one of the things we don't know is really what the enza response is in this group of patients.
Right, well, so there's a couple of good points there. Let me just say, what if this patient's PSA was rising from 0.2 to 0.6, and his pain was actually stable, and he's been on the abiraterone for 18 months. In that situation, with a little more detail now, and let's say that the multifocal bone lesions are stable, right? So that's a very different situation.
Yes, it is.
That's a patient who we're going to keep on the abiraterone.
Yes.
The implication in the case is that his PSA is rising significantly. He may have new bone metastasis, and his pain is new.
Absolutely.
And that suggests that there's an evolution underway, and I think that's just an important clarification.
And this also is an important point for clinicians as well. I mean, I've seen, and this was part of the papers that you wrote, that there are patients who have these persistent PSA rises or consecutive PSA rises, and you re-image them at regular rates, and there's no change in the imaging. And so then the question is, what do you do? How long do you keep them on the drug? I'm following somebody right now whose imaging has been stable now for about 9 months, and his PSA has been rising slowly.
Do you get scans on an abiraterone patient on a routine basis, even if they're responding?
I generally will get it based upon PSA.
So if a patient's had a 90% decline in PSA, you're not going to be getting CAT scans or
no, because
scans?
I'm not going to change my treatment based on that.
I'm the same. Others would argue that perhaps we're going to miss the emergence of some of these non-PSA making tumors, but those are pretty rare. And I'm actually backed up now with the data that the small cell and the neuroendocrines actually make PSA. That actually is, in a way, oddly kind of helpful.
Well, so one thing I do sometimes on that is I kind of get my nadir imaging, if you will. And so particularly with patients who may have had bulky disease in the beginning, and I don't image them because I'm expecting to find anything new. I'm imaging them because I really want to get a new baseline. And so with a good response, I kind of want to re-baseline them, really understand how the status is, and then that next time I image, I've got a new baseline to compare it to.
But then what's your trigger point? I mean, it's usually PSA, but the other thing too that goes along with the small cell and the non-PSA progression is if they start losing weight or they start getting sick. I mean, that's the other situation you have to go forth with. But I've seen this too, where you've had high elevated PSAs and small cell in the liver, and you biopsy the lymph nodes and you've got adeno in the lymph nodes.
Yeah.
So this is often a mixed picture
Yes.
that exists, and I think we're seeing more of it with the selection factors that we're giving with these treatments.
Let me circle back to the points we made on the previous case, which is this is also a time when if the pain is stable and everything looks okay, but the PSA is rising, I'll get an alk phos, LDH, albumin, hemoglobin. Those are those prognostic variables, and if those start to rear, if declines in hemoglobin or albumin or rises in LDH begin to rear their ugly head, then we know something's brewing, and so that would be a situation where we might say we should discontinue the abiraterone. One more quick point, and I'm speaking about abiraterone, it's the data I know best, but I think it probably also applies to enzalutamide, that in the abiraterone study, in which there was a placebo and prednisone arm, and then there was an abiraterone and prednisone arm, the median time to PSA progression in the placebo arm was about 3.5 months. The median time to radiographic progression was about 8 months. So there's a delta there, right? The delta between time to PSA progression on average in the abiraterone and time to radiographic progression was about 7.5 to 8 months. So that was a longer delta than in the placebo arm, suggesting but not proving that continuing despite a rising PSA may continue to provide some benefit.
Right.
Howard Scher spoke this morning. He talks about these drifter patients, and I like that term. PSA goes down and PSA drifts up. And I think one of the key messages I would like to get across to clinicians is to not give up too soon, that these therapies may in fact be benefiting patients, but to follow those parameters, whether it's imaging or LDH or whatever that says, to figure out when the point is when you should discontinue.
It's a tricky issue.
It's a tricky issue.
Yeah,
Exactly.
I mean, because this sort of no longer clinical benefiting. We talked about Howard Scher today in the Prostate Cancer Working Group 3, and it's interesting. We should probably practice together because I'm like you. I'm looking at the albumin, the alk phos, the LDH. I'm starting to kind of scrutinize what's going on a little bit. I'm seeing the patient a little more often, and I may be starting to do some scans because even though you cite the medians, of course, there's a lot of differences around the median. But it's something that has to be highly individualized.
Yeah.
And I think just about this time we make up good rules, I'll find you about 3 exceptions to that good rule.
Right.
We actually sat down about 2 years ago and wrote this paper called Radar, which looked at when you should image the patients. And basically what we decided was probably after a PSA of 2 and then every doubling time thereafter. But there's really no set way to re-image these patients. And again, you don't want to miss something, but at the same point, you don't want to unnecessarily expose the patient to radiation therapy, radiation treatment, radiation.
Yeah. So we've talked about the choice between radium and docetaxel. I think you made a really nice discussion or argument for why you would choose one over the other. And the choice of going from abiraterone to enzalutamide or enzalutamide to abiraterone is something that remains a bit, controversial, and we're looking to figure out whether a biomarker is going to help us in that setting. The reality is, when you present patients with the case of going to chemotherapy or intravenous radiation, as I call it sometimes, or the second oral targeted therapy, patients will frequently say, why don't we just start the second oral targeted therapy? And a lot of clinicians are that way too. It's easy to go to that second one.
Yeah.
Should we be doing that though?
Well, it's interesting. In this type of patient, I really don't know the answer. And for the type of patient I think who's a more rapid progressor, I feel a little more confident going to chemo. But one of the things that I've been doing, and we're thinking in sequence, drug A, then B, then C, and we are in fact putting together the enzalutamide radium patients. And in some of the patients in this very setting, we're treating with that combination. Now, what does it mean? I don't know. Am I going to suggest other people do it? No. But I really want to know the answer. I do like the idea of radium in this type of patient, but I know radium monotherapy needs some help. Whenever I'm giving radium, I'm always giving it with another hormonal agent. And if I don't have a hormonal agent that I have any confidence in, I'm not going to use radium.
You're always giving it with the second hormonal agent.
Always.
Ah, interesting. Chemotherapy? Do you ever combine it with chemotherapy?
I have not been. I'm very well aware of Mike Morris's clinical trial. He had to reduce the dose on the abiraterone, reduce the dose on the docetaxel, and reduce the dose on the radium. I have not been combining it with chemo.
Yeah, we participated in that trial, and the issue is that the docetaxel dose was reduced down to 60 milligrams per meter squared, still within the range of survival benefit, as you both know, and so a reasonable thing. But I do agree that I actually think that chemotherapy plus radium deserves further study, because as we've been discussing, there's probably a subset of patients for whom that's a particularly good therapy.
Yep. But at the same time, when you look back at some of the failures that we've had in combination therapy, that in part may be attributed to lower doses of docetaxel, and in the experimental arm. So I think it needs further study, and the issue is there real synergy between a taxane and an isotope? And I think that there's preclinical justification, but I would be very, very careful.
Isn't it unusual or interesting that we to date have not effectively combined two agents with individual survival benefits together? So radium, docetaxel, they both have survival benefits. Radium plus docetaxel, we'd like to see what that does. All of the combinations that we've done with docetaxel have been with drugs that we didn't know what their benefit was.
Right.
But we have data with cabazitaxel and abiraterone. There's data with docetaxel and abiraterone as well. And I think that that's also an important fact. I mean, what's the effect of stopping abiraterone in this situation? Are you putting gasoline on the fire by allowing release of intracellular testosterone? Or are you, as years ago, priming the cells to cycle and then giving a chemotherapeutic agent? Nobody's really answered that question sufficiently.
Yeah, thank you, Dan, for raising that. I mean, it's a really, really good point. You know, we have lived in this sort of sequential world, the ABCD world, and yet we really don't know if we should be continuing abiraterone and adding something to it or just stopping it. And as Dan points out, you know, you're inhibiting this machinery, 17-alpha hydroxylase, 1720 ketolase. When you stop ABI, you're going to have some intratumoral androgens that are going to start bubbling up. And I'm not sure that that's really a good thing. So, you know, I'd almost prefer to be doing some more trials trying to ask the question, does continuation of ABI make sense or not? Because right now we're just kind of stopping it and moving, and that may or may not be the right thing.
And there was a publication that looked at docetaxel after abiraterone, and a lot of people concluded that it's not as active. Well, is that because the abiraterone is being stopped? And perhaps it should be continued. We don't know.
You mentioned it really quickly. I just want to clarify that you have participated, as have I, in studies that have studied cabazitaxel in combination with continued abiraterone.
Correct.
And that has not yet been studied definitively, but we do know that we can combine those two agents, and that would be the strategy.
And the same with docetaxel. You can give full doses of both drugs safely.
Right.
Yeah. So one thing I'd like to bring up, and Chuck is more than aware of this. It was kind of interesting that both he and I and a Canadian were both sitting around in independent places coming up with similar ideas, and there's going to be a new trial called PromCab. And Chuck is one of the PIs, I'm one of the PIs, and a fellow named Fred Saw is one of the PIs. Mike Morris is going to join us. And we're going to be asking questions in this type of, actually not quite this type of setting, it'll be the early abiraterone failures. Should they go into enzalutamide or should they go into a taxane? In this case, it'll be cabazitaxel. And we'll be randomizing and looking at those outcomes, and that'll be a chance for us to be working closely together.
I think it's a really good practical clinical question, and it's going to address some of the biomarker issues. But you're bringing up the use of cabazitaxel as frontline chemotherapy, not as post-docetaxel. So what are your thoughts on that?
Well, you know, we have a very important trial that's going to report later this year. It's called Firstanum. And just as soon as cabazitaxel got approved in the post-docetaxel setting, the question immediately arose, of course, well, which is better in the front line, so docetaxel or cabazitaxel? So there's been a large phase 3 prospective randomized trial, fully accrued at this point, just waiting for the outcomes, which will be overall survival. And it'll be comparing cabazitaxel, docetaxel head-to-head. And of course, everybody knows docetaxel is hard to beat. Dan,
absolutely.
Dan moved early on that one, and we're still taking advantage of his experience. If it does beat docetaxel, it'll be the very first drug to do so. So, you know, if we look at it that way, it's like a really high hurdle to jump over. But nevertheless, the trial's accrued, cabazitaxel versus docetaxel frontline. We're going to find out the answer later this year.
Just to complete the points on cabazitaxel and radium and docetaxel, Dr. Petrolak, your thoughts on sort of the sequencing of, you know, do you go docetaxel to cabazitaxel? Do you give patients a chemotherapy break? Maybe use radium if you're going to do anything? what are your thoughts on that chemo? That's
It all depends upon how the patient's feeling. I mean, again, without any sort of markers, I look at the patient. I mean, if they've gotten beaten up by the first cycle of chemotherapy, I'm going to tend to go on something like radium or another hormone. If they've had a very, very short duration of response to their initial hormone therapy, I'm going to tend to try to push more chemotherapy, such as cabazitaxel. I think that's a fairly good indicator as to how they're going to do on subsequent hormone therapy.
terrific.
Yeah, so in the TROPIC trial, which was the phase 3 with cabazitaxel, and that was compared against mitoxantrone, it turns out that the patients who probably did best on the second taxane were the ones that did best on the first taxane.
Yeah.
And it might have some analogy to what we were discussing earlier. It could be the patient who does best on the first hormone may have an opportunity to do better on a second hormone, but I can say absolutely in the taxane setting it's true.
Right.
Patients with a response, then relatively slow progression, moving on to cabazitaxel, post-docetaxel, that's actually a very good cabazitaxel patient.
Yeah, absolutely.
Great. Well, as usual, great talking to both of you. Enlightened. I've learned a lot sitting here listening to you talk, and I hope the clinicians out there listening have had a similar opportunity as me and have gained from your insights and some of the new data that we're seeing this year at ASCO and have been published recently. So it's really been a pleasure. Thank you.
All right. Thank you, Chuck.
Thank you for watching Evolving Paradigms in Castration-Resistant Prostate Cancer.